Hey guys, Eric back with you with FlightBridgeED. Today we're going to go through a pretty thorough podcast on sepsis, and if you have listened to all the podcasts, we've kind of started from the cellular respiration aspect, and we're slowly building up and building on our knowledge, and that's basically called chunking as far as teaching goes. So hopefully every podcast will build on that knowledge that we've learned from previous podcasts, and then you can always go back and refer to the other or older topics to review. And I thought it would be fitting that we would talk about sepsis and kind of the guidelines as it relates to the ICU and how they relate to pre-hospital medicine, whether you're EMS or you're a rotor flight crew member. So a little bit of background on sepsis. We have different layers or different aspects of the sepsis disease process, and everything starts by a infectious process or a source. And as paramedics, or especially paramedics out in the field, a lot of times we get these patients from the nursing homes, or we get these patients as transfers, and we really don't look or understand what goes into the whole disease process prior to our transfer, or the initiating or precipitating events that led to the infectious process. So we'll go into that pathophysiology, but remember, everything starts with an infectious process of some sort, and that leads to what's called a systemic inflammatory response. And our body has this response based on multiple different things that happen injury-wise, and we've seen that in the earlier podcasts as we've talked about ARDS, and we've talked about the trauma patient. And when we talk about this massive inflammatory response, this is our body's way of trying to fix or heal itself. And what it really does, because of this massive inflammatory response, is it starts breaking down our vessels and our lung tissues, our epithelial tissues, and it starts killing itself. And so we've talked about that in other podcasts, how our body has these mechanisms that try to solve the problem but actually make it worse. So the inflammatory response is, again, based on the source, and a source would be some type of infectious process, perforated bowel, a ruptured appendix, a gangrenous gallbladder, anything like that would cause a massive internal infection. What is a SIRS response? And if you think about everything we do in medicine, there's classifications, and with this you have to have two or more of the following things. So you have to have either a temperature greater than 38 Celsius, or you have to have a temperature lower than 36 Celsius. So you have to have either a hyperthermic state or a hypothermic state as it relates to the body and fighting that infection. You have to have a heart rate greater than 90, which really, if you look at that, that's not very high. Your respiratory rate, they got to be a little bit tachypnic, or they have to have a CO2 level lower than 32 that's concurrent. So remember, your first stage of shock is always going to be a increased respiratory rate. You're going to have a metabolic, or a respiratory, I should say, alkalosis. So you have to have a CO2 level lower than 32 millimeters of mercury. And then you have to have some increased white count greater than 12,000. And you're always going to see that initial spike in your white count, and as the SIRS response progresses, you'll see it start dropping, and you could also have a low white count. So if it's lower than 4, then you know that you have an infectious process as well. So you have to have two of those categories. And really, you could look at that, and really I look at that and I see that that's pretty vague. I mean, you got to look at some other issues or other things lab-wise that would probably clue you in to this being a SIRS response. Oftentimes, though, our patients, we don't see our patients at this level. We see our patients that have waited to the last minute to call 911 or go to the hospital, and they're in the actual sepsis stage, where you have a massive infection that's coupled on top of this SIRS response. And then it progresses into severe sepsis, where severe sepsis, you have actual organ dysfunction, you have hypotension, you have hypoperfusion, You have lactic acidosis. We'll talk about that. You have low urine output. You have mental status changes and things like that, where these patients may need to be intubated. You have then septic shock. Septic shock is going to be where you have a sepsis-induced circulatory failure. So these patients are persistently hypoperfused, and they have a low blood pressure regardless of how much volume you give them. And so these patients need to have pretty aggressive airway management. They have to have pressor medications to cause vasoconstriction to try to improve or increase that cardiac output. So we'll talk about all those things. So those are kind of the 4 levels as it relates to sepsis, or the stages of sepsis. So we have the surge response initially, then we progress into sepsis, and then we go into severe sepsis, where we actually start seeing the increased lactic acidosis, the decreased urine output, mental status changes. A lot of times this is where we actually find our patients. And then we have actual septic shock, and this is the very later stage, very poor prognosis, where we have massive hypoperfusion, tissue hypoxia, anaerobic metabolism, and things like that. And so we'll get into that. Going back to this inflammatory cascade, we've talked about this in the ventilator management course. We've talked about this in other aspects of these podcasts. And so we have mechanisms in our body that cause inflammatory responses. And so with anything, your body has this infectious process, and it's going to try to fix it by increasing or releasing inflammatory cascades. These pro-inflammatory cytokines or mediators start breaking down this epithelial tissue that's in our body, and we start actually having increased capillary leakage. And this is something that's very important to understand in sepsis, is we have to give them tons and tons and tons of volume, because they have this massive capillary leakage. And this leakage, they start losing all this intracellular, intravascular fluid, and it starts third spacing. And so you see these sepsis patients that are big and puffy and swollen. It's because all that fluid is being leaked out and third spaced into these areas, these interstitial areas. So we have to constantly be aggressive with our fluid management. But because of this, we have other problems. We start having coagulopathies, we start having DIC, and then we have an immune system that's so paralyzed that it can't even fight the infection. So you have multiple areas where this pro-inflammatory response causes a cascade of events that actually kills the body. And we're constantly trying to fight against that. So what do we do? As it relates to sepsis, let's talk about a few signs and symptoms. So again, you have a fever. You have a patient that's got to have a fever, or they may be hypothermic. They may have some unexplained tachycardia. So if you ever had a patient that's got unexplained tachycardia, always rule out a temperature. I actually saw a physician one time cardiovert a guy 6 times because the heart rate was in the 150s. Constantly kept cardioverting the patient, actually gave antiarrhythmic medications to try to convert the patient, and it wasn't until another physician walked up and said, what's the patient's temperature, and it was actually a fever of 104 that was causing the patient to be hyperthermic. And this physician was an outstanding physician, and so anybody can miss this. So always rule out fever. Unexplained increased respiratory rate. Remember, that's going to be your initial first response in any shock situation. So we need to identify why that is, and you're going to see that on a blood gas with a initial respiratory alkalosis. Signs of peripheral vasodilation. So do they have a container failure, right? Is this a distributive shock? They have a hypoperfusion state. They have a hypotension that's not being fixed by fluid resuscitation. Are there any unexplained mental status changes? Do we have any thing as it relates to other disease process? Do they have diabetes or acute renal failure or things like that? Or is this unexplained? And then you have an increased cardiac output and a low SVR. So, your cardiac output is going as fast as it can, and you have a low SVR, and so your systemic vascular resistance is low. You have this container failure, distributive shock, and so we need to try to fill that container up. when we get into treating sepsis, what do? Well, the first thing, and these are the aspects of sepsis that we don't see in EMS. We see it a little bit in the flight industry, as a flight crew member on a rotor aircraft or fixed-wing aircraft. But you have to find the source. And so, this is, again, done without us prior to us transferring the patient a lot of times. And so they need antibiotics. They need an antibiotic that's very broad spectrum, that's going to hit multiple different levels. Because you don't know where the source is initially. And so I think it's very important for them to get the antibiotics on board within an hour of onset once it's recognized that they're having a surge response. It's very, very important. All right, and the next thing we need to look at is we need to look at different aspects of labs that can help you predict tissue oxygenation. And you remember in the cellular respiration podcast, we talk a lot about how everything starts with oxygenation. I mean, every disease process, everything we do starts with oxygenation, and so we need to optimize that. And there's things in sepsis that will gauge true tissue oxygenation very, very accurately. And so the first thing we want to do is check a lactate level. And again, based on the earlier podcast, we talked about a lot of smaller facilities don't draw lactate levels, and that's very unfortunate. You see this in the bigger facilities, the higher level ICUs, and so we don't get a good practice at looking at labs and things like that. But if you have a lactate level greater than 4 millimoles per liter, that's indicative of severe tissue hypoxia or anaerobic metabolism. It's even a bigger biomarker as it relates to mortality and morbidity and actually the level of the sepsis. So that's very important to identify a lactate as quickly as possible and start fixing that problem by what's called lactate clearance, and that's giving volume, optimizing tissue oxygenation by advanced airway management and ventilator management strategies. The next thing we want to do is we want to look at a central venous oxygen saturation, and we don't normally do that in the EMS realm. We just look at an SaO2, which is the concentration of hemoglobin as it relates to oxygen attached to it, but we don't really look at an SVO2. And an SVO2 is either going to be a mixed venous gas, which would be a PA catheter, so it's looking at at a wedge, and it's looking at deoxygenated and oxygenated blood kind of combined, or for this purpose we're just going to talk about a central venous oxygen saturation, and we want to try to maintain that at greater than 70%. And so this is what they're doing in the ICU, is they're watching that, they're trending that, and this is a very accurate way to identify tissue oxygenation, because it's looking at the venous tissues, and we know that's in the fingertips and it's in the extremities. And if you can identify a good oxygenation at that level, you know that you're perfusing and you're getting good tissue oxygenation. So you're trending this central venous oxygen saturation very closely. You start seeing a trend downward where you go from a 70 down to a 65. That's probably going to be the earliest indication that you're actually going downhill, that your patient's not doing well, and so then you need to start looking at strategies to improve that, and we'll talk about that. Crystalloid boluses. Sepsis patients need volumes and volumes of fluid, and I don't think that you and I, prior to maybe getting into critical care, could fathom the amount of fluid that they need, but because of this severe inflammatory cascade that happens, and they have this capillary leakage, it's severe, it's systemic. And so they're constantly leaking all this fluid into the interstitial space. And so they're always behind on their fluid. So the initial therapy of fluid replacement for these patients is giving a 30 mils per kilogram bolus every hour, and watching their blood pressure. And they're doing this by also looking at a CVP, central venous pressure. And so this is something that's put in the subclavian vein, and it's ran into the right atrium there, and it's measuring right atrial pressures and right ventricular pressures, and what's being exerted preload wise. And so we know a CVP is very accurate as it relates to volume. If we have a low CVP, we know our preload is low. We have a higher CVP, we know everything in front of it So what I mean by that is, if you have a CVP that's high, you know that maybe something in the left ventricle is backing up, making that high. So you always have to look at downstream what's causing that. But for the purposes of sepsis and volume replacement, we're trying to maintain a CVP of 8 to 12 millimeters of mercury, and a normal CVP is anywhere from 2 to 6. So we're trying to optimize that. We're trying to fill the container up even more, and that's a great gauge in identifying your fluid replacement. So we're not just giving tons of fluid empirically, and what I mean by that, just by giving fluid and not wondering what it's doing, we're actually identifying the fluid boluses based on a CVP of 8 to 12. So what kind of fluid do we use? Well, there's arguments against normal saline. There's arguments against lactated ringers. Remember from the earlier podcast, and I'm not going to go into it in depth, but your normal saline fluid is a very acidotic fluid, and if you give abundance of this, you're going to get what's called a hyperkalemic acidosis or metabolic acidosis. So it's actually going to be adding to that metabolic acidosis already. So we need to be thinking about that when we start giving fluids. And then you have LR. LR is not quite of an acidotic fluid. It's more of a base, a neutral fluid. I believe the pH is about 6.7 to 6.8 versus normal saline's pH is 6.0. LR has got a sodium and a chloride that's very close to us, about 140 for the sodium and 102 for the chloride, whereas normal saline, your sodium is like 155 and your chloride is also up in that range as well. So that's why you can get this hyperchloremic acidosis with excessive amounts of normal saline. As far as the LR, you do have a lactate additive to it, so you know that sugar additive is could potentiate and increase your your lactic acidosis, I guess. So once you're getting massive amounts of fluid, then you need to start looking at different aspects of colloid administration, giving FFP, giving albumin and things like that. But those are things that we would see maybe in the transfer setting, and we wouldn't be initiating those things in these patients. But we need to understand that's going to be better for your patient. You don't want to cause massive washout, and it's the same strategy as we kind of look at with our trauma patients. You don't want to cause that massive washout. So we need to maintain a good tissue oxygenation. We need to fill the container, but we need to be looking at those parameters and not give too much fluid to cause that washout to increase the incidence of DIC and things like that. So what we're looking for again is we're looking for a CVP of 8 to 12. We're trying to look at a MAP pressure at 65. We know a MAP pressure at 65 is going to perfuse our brain. It's going to give you a good cerebral perfusion pressure of at least 70. We know that that's going to hopefully perfuse our kidneys optimally and optimize tissue oxygenation systemically by doing that. Obviously, there are patients that have a peripheral vascular disease. They have a history of hypertension that can cause problems. And so for those patients, we actually want to increase our CVP to about 12 to 15 millimeters of mercury because of that systemic vascular resistance is increased in those patients automatically. And so if you identify your patient has a history of hypertension, has a long history of artery disease and things like that, for tissue perfusion and your fluid resuscitation, you want to maintain a CVP of about 12 to 15. Again, maintain a MAP maybe a little bit higher, because remember, if you have a MAP of 65 with a normal, healthy 18-year-old male, that MAP of 65 is probably perfusing everything. You have good warm tissues, good warm hands and extremities, where if you have a 60-year-old male that's got extensive hypertension history and artery disease and things like that, a MAP of 65 may be a false map. And what I mean by that is everything's shunted to the core, and their tissues or their extremities and their hands are still ice cold, and that means that map is not perfusing things to the tissue level, and that's where you're going to see that low central venous oxygen saturation. Remember, we talked about that SVO2 wanting to maintain that greater than 70%, and that's a tissue marker of venous perfusion. All right, so I know that's a lot, but we want to just continue to maintain that central venous oxygen saturation greater than 70. If you start dropping that saturation and you can't get it up, we need to be looking at different aspects of your labs. And remember, we have our oxygen carrying capacity, right? And that's a hemoglobin concentration. If we start giving massive amounts of fluid, that concentration is going to decrease. So if you get a central venous O2 sat of less than 70 that you can't increase, you're going to want to start improving that by giving packed red cells, FFP, and platelets and things like that to try to optimize your oxygen carrying capacity. Remember from our earlier podcast, oxygen carrying capacity is a pretty neat thing, and we need to always remember that, how our body processes and utilizes oxygen, how it utilizes that and sugar for ATP production and things like that. And so we have to try to optimize that. And so remember, your tissue oxygenation is dependent on oxygen carrying capacity and hemoglobin concentration. So always be looking at your H&H, identify if they're anemic, identify if they have a low hematocrit, and optimize it that way. And then if you can't get a good SvO2, you can't optimize your MAP, you can't get a good CVP, then that's where we're starting to get into severe septic shock. And we need to be aggressive in our pressor medications. And so let's assume, based on this presentation, that your patient is intubated, they're on the ventilator, and so we want to optimize oxygenation with the ventilator. We want to make sure we're utilizing an approach that's going to decrease the incidence of ARDS. We want a lower tidal volume, start at 6 mils per kilogram, utilize a little bit higher PEEPs, try to optimize that recruitment, maintain that good alveolar recruitment. So we've taken care of the airway aspect. Now we need to make sure we're taking care of the circulatory aspect. We're making sure that we optimize perfusion. And the only way you can do that in these patients, you've given the volume, you've given the colloids, you've identified your SvO2, you've identified your CVP, remember, of 8 to 12, or if you have somebody in hypertension, you want to maintain a CVP a little bit higher. So then we get into our pressor medications. And so I get asked all the time, well, what are the best medications to utilize in a severe septic shock patient? Well, EMS-wise, we have always just jumped into dopamine, and dopamine is a standard EMS paramedic medication pressor that we would utilize. In my experience, I've utilized dopamine quite a few times in cardiogenic shock situations, and it's worked very effectively for me. But as far as the sepsis guidelines nowadays, dopamine is kind of a last line thing, and dopamine is not a very good medication. And so the first line medications that are utilized in septic shock are sepsis patients that are have refractory hypotension, regardless of how much fluid volume, colloids, things like that we've given, is norepinephrine or Levophed. And back when I started EMS, Levophed was kind of looked down on. It was Levophed, leave them dead, and we didn't utilize it. And it wasn't a good medication. But for purposes of septic shock and this type of patient, it's excellent. Remember, it has very good alpha effects. It doesn't really affect the heart rate, and so you have good systemic constriction that's going to optimize tissue perfusion. Remember, this is a distributive shock, so you have a massive container failure. You're always behind, so we need to optimize that. Second medication would be epinephrine, an epidrip, just a standard epidrip. Is going to be excellent for this patient, and I think that's probably forgotten. I don't think many people think about using an epidrip, but that's always a great second-line medication. And then there's always neosynephrine. Neosynephrine is another excellent medication. It's also going to be second-line, and so first-line being Levophed and Epi, you could probably use those interchangeably. Levophed is probably going to be my first choice, and then norepinephrine, or I should say, and then neosynephrine is going to be my second choice for these patients. And it's going to be an excellent medication to cause profound alpha effects. And then if you need another medication that has an inotropic effect to it, you can always jump in and use dobutamine. Remember, there's some negative things about dobutamine. You always want to make sure that container is full as best we can. We always know that dobutamine needs to be piggybacked with another medication, so never give it by itself. Utilize dobutamine as a inotropic medication to affect squeeze on the heart. And so now you've got a medication like norepinephrine or neosynephrine that is causing systemic vasoconstriction, and now you have a medication like dobutamine that's going to cause a little bit better squeeze, and you're not going to have the heart rate effects of it. Remember, dobutamine is going to cause an initial vasodilation. It basically causes a relaxation of the heart, but it also causes the heart to work more effectively and squeeze a little bit more efficiently. And so that's kind of the mechanism of it. So excellent medication to piggyback with either norepinephrine or neosynephrine if you choose to. I encourage you to try that out. So when we look at examples of how this progresses negatively, I mean, you can get these patients that are so sick that despite your management of optimizing your CVP, as we've talked about earlier in the podcast, if you have the capabilities of looking at an SVO2, I know some of you have probably never heard of an SVO2. SVO2 again is going to be the probably the most accurate way to identify tissue oxygenation, tissue perfusion. Looking at your lactate, trending that lactate and identifying if it's trending up or down. Remember that your lactate level normally is 2.5 or lower, and so when you have a surge response and you check a lactate, for every point above 2.5 you have a 10% mortality rate. So again, it's looked at as more of a biomarker for morbidity and mortality. So these patients, they have this massive surge response. You're managing them appropriately. You're doing everything you can. You've tried to identify the source. If it's a source that needs surgical intervention, then obviously that needs to happen. You have an antibiotic that's on board that's broad spectrum, and we've identified that, and we've started that early. Remember, that has to be started immediately to really try to combat this infection. And then we look at the CVP, we look at the SVO2, we optimize our fluid resuscitation based on the 30 mils per kilogram fluid boluses. And those are big fluid boluses, guys. Remember, 80 kilogram patient, you're talking about 2 liters. So sepsis patients, in all reality, could get 5 to 10 liters of fluid a day. And you can see how that can potentiate and cause, absolute reduction in hemoglobin concentration. It can cause, the DIC process, the same philosophy as we've talked about with our trauma patients. And on top of it, you have this massive inflammatory response that's actually causing the whole DIC cascade to begin as well. So these patients are very, very sick. There's multiple pathways that you have to treat. And for our time with our patients, whether it's a half-hour flight or an hour flight, we got to think about what we can do to try to optimize that. And a lot of times, it really is only going to be optimizing our ventilator management strategies. We've talked extensively about that, and if you've heard me speak live about ventilator management, I'm very passionate about utilizing good strategies that reduces ventilator lung injury, that reduces the incidence of ARDS. We want to identify if that's a problem. We want to increase our PEEP. Even though you may have a patient that's a little bit hypotensive, PEEP is a good thing. You can augment that with your pressors. We've already started our drips, our Levofet, our Epi drip, maybe our neosynephrine drip. And you got to think about other aspects. You want to sedate your patients effectively with fentanyl drips and maybe a little bit of Versed. Remember, fentanyl is going to be very stable on a blood pressure. Even if you have a patient that's in severe septic shock and has tissue hypoperfusion and things like that, fentanyl is going to be a good thing. We want to maintain a good urine output. Remember, a peeing patient is a stable patient per se. So we want to maintain a good urine output. 30 to 50 mils per hour is what we want to try to achieve. And so we're constantly going to be looking at our labs. So for purposes of flight nurses and flight paramedics on the ambulance, and I encourage you your paramedics on the trucks right now, anytime you do a transfer, pull those labs out. That's going to be probably the biggest learning curve for EMS people, is look at those labs, remember what those are, identify what they mean, ask questions, ask your medical director, and start understanding what those things mean, because we can trend our renal functions by our BUN and creatinine. We can identify if we have other problems with our H&H, and we can look at strong acids and weak acids. We can look at our anion gaps, and we can look at our sodium and chloride, and we can look at our albumin levels, and we can look at all those things and understand truly what's going on with our patient. And then obviously, if you can get a blood gas with these patients, I think that's essential. We don't want to ever sit at the bedside forever and get a blood gas, but if we can get a blood gas, it's going to really be able to help us tailor our approach to ventilator management strategy-wise. So kind of back to our approach as it relates to transport, we really want to look at optimizing our ventilator management strategies, optimizing our tissue oxygenation, being aggressive with our pressor medications to optimize that perfusion, and just continue the care that's already been started. So this podcast is a little bit longer, but I really wanted to focus on, the whole aspect of the treatment as it relates to start to finish, things that we really don't see, and we don't really get to identify during a transfer. We miss a lot of the pre-treatment, and we don't really understand what goes into these patients. So just be good to your patients as it relates to being aggressive with your airway. Remember, if you want to refer back to the podcast on ventilator management and ARDS, we don't want to cause ARDS, and a lot of these patients that are septic go into ARDS because of, again, this massive inflammatory cascade, these cytokines that attack the epithelial tissues. It's not just attacking the vessels, it's attacking the lung tissues as well, and you get these vascular permeability that gets real poor, and this massive fluid shifts. So very complicated, very sick patients, and they can be very confusing and overwhelming to us that haven't dealt with them. And so hopefully this podcast kind of sheds some light on the sepsis guidelines and all the things that goes into treating these sick patients. If you have any questions or comments regarding this podcast, or any further topics that you want me to go over, I would love to hear about them. You can email me at eric@FlightBridgeED.com, and we'd love to hear your comments. So thank you so much for listening, and we'll talk to you on the next podcast.